Assalamu alaikum. Our lecture today is the continuation of our previous lecture about the stomach and the duodenum. أول موضوع راح نحكي عليه هو congenital hypertrophic pyloric stenosis. The congenital pyloric or hypertrophic pyloric stenosis, the etiology of this condition is unknown, but it includes genetic, environmental factors, although specific gene has not been identified. It is recognized to have a familiar tendency. 80% of cases occur in male infants. 50% are in firstborn. There is also association of this condition with administration of macrolide antibiotics like erythromycin to the mother in the late pregnancy or to the infants in the first 2 weeks of life. The clinical feature of this condition, the child usually presented at 3 to 4 weeks of age. The symptoms may be presented at soon or at the birth or soon after birth. It is extremely uncommon for a previously healthy infant to develop this condition after 12th week. The presenting symptoms is projectile vomiting. The vomit never contain bile, and the child takes food immediately after he vomits, and the child is always hungry. There is failure to gain weight as a result of dehydration, and the baby is constipated. And on examination, we could see the visible peristalsis of the dilated stomach in the epigastric region, and 95% of infants have a palpable pyloric mass, which is firm in consistency. The differential diagnosis of this condition: neonatal intestinal obstruction due to duodenal atresia, volvulus neonatorum, or intestinal atresia. This presented with vomiting, and it contained bile. And also this condition, due to projectile vomiting, should be differentiated from intracranial birth injury. Sometimes the families give her baby overfeeding. There are no other features to suggest pyloric stenosis apart from vomiting. Special investigation. شنو نسوي له investigation هذا الchild اللي presented by such a condition? Usually who are referred from the pediatrician. When we examine the child, we see the child emaciated, underweight, with visible, as I mentioned, visible peristalsis or mass palpated in the epigastric region. Ultrasound scan to demonstrate the thickened and elongated pylorus with a large stomach. No further studies required. Sometimes abdominal X-ray or barium study, which is rarely needed. The treatment of this condition: in more seriously infant or child, we need a time to rehydrate that baby to correct the hypochloremic metabolic alkalosis. Need about a day or two or more, and doing gastric lavage with fluid replacement, potassium, added to saline, and the child referred to the surgery. Surgery by Ramstead pyloromyotomy. This done through an incision through the thickened pylorus down to the mucosa. Usually those child will do well, and there is no complication after surgery. And we should take care of the mucosa, not to breach the mucosa or not to penetrate the mucosa. Returning back to the anatomy of the stomach. The anatomy is important in surgery. As you know, the stomach divided into 4 regions: fundus, cardia, body, and pyloric part. The fundus area, as we could see here, sometimes it's hidden a pathology. So during a gastroscopy, we have to do a J maneuver to see these blind areas in the stomach. And the pyloric canal then to the duodenum, which is about 20 to 30 centimeters in length, which extend from the pyloric sphincter to the ligament of Treitz. To study any anatomy, we have to study the blood supply of the stomach. The stomach receives very extensive blood supply through celiac artery, right gastric, gastroduodenal artery, and the splenic artery through the left gastroepiploic and right gastroepiploic artery. The lymphatic drainage of the stomach is important, especially when we are dealing with the resection or tumors of the stomach. We have celiac groups, splenic, gastroepiploic group, and subpyloric group, omental group, and the gastric group. Again, this slide showing the lymphatic drainage of the stomach. The blood supply of the duodenum, mainly through the superior mesenteric artery, by by celiac, by gastroduodenal artery, and this is the posterior gastroduodenal artery, which may get involved by the ulceration through the posterior duodenal ulcer. The posterior duodenal ulcer tend to bleed, while the anterior duodenal ulcer tend to perforate. البنتريشن يعني penetrated ulcer, it will involve the gastroduodenal artery producing hematemesis or meninam. Okay. In summary, the anatomy and physiology of the stomach نقدر نلخصها كم نقطة. The stomach acts as a reservoir for food and commences the process of digestion. Gastric acid is produced by proton pump in the parietal cells, which in turn is controlled by histamine acting on the H2 receptor. The proton pump inhibitors abolish gastric acid production, whereas H2 receptor antagonists only markedly reduce it. The gastric mucosa layer is essential to the integrity of the gastric mucosa. موضوع آخر هو حقيقة interesting إنه هو ال stomach disorder. Stomach disorder by definition the presence of large masses of indigestible fibers within the stomach. We can classify disorders into the following. Phytobezoars, which is a bezoar made up of vegetable fibers. Trichobezoars, which is made up of hair, and it is usually seen in a young woman and children with mentally impaired or psychologically impaired personnel. And the other type of bezoar is pharmacobezoar. قسم طبعا يسموها بيزور أو قسم يرفضوها بيزوار. Pharmacobezoars, it is a medication bezoar. It can occur when a patient ingests large quantities of fiber containing or extended release medication that are difficult to be digested. The clinical feature. Majority of the patients with bezoars, except the trichobezoars, have a predisposing factor for developing such a condition. With the slow down gastric emptying, such as a prior gastric surgery. يعني هاي ما تحدث يعني ما عدا بالترايكوبيزورس دول جماعة الفايتوبيزورس and فارماكوبيزورس. عادة دول يكون عندهم عمليات سابقة اللي بالستومك or duodenum اللي lead to stagnation or sometimes due to lack of teething and proper mastication and the presence of diabetes mellitus and end-stage renal failure or renal disease, or a patient on mechanical ventilation. Many patients are asymptomatic. Most of them complaining of gastric discomfort, anorexia, nausea and vomiting, weight loss and early satiety. Gastric ulcer may develop due to pressure necrosis of the gastric wall. Large bezoar can cause gastric bleeding and gastric outlet obstruction. Bezoar may extend from the stomach, يعني تمتد هاي البيزورز تاخذ شكل المعدة والبايلورس والديودينم and causing of obstruction. هاي حالة يسموها Rapunzel syndrome. This picture, this is a barium study, barium meal showing filling defect here, big filling defect in the stomach, which is proved to be a bulk or of hair or mass of hair ingested by a mentally retarded female. موضوع آخر مهم we are going to talk and mentioned in the previous lecture هو كان peptic ulcer disease. Peptic ulceration develops when a breakdown in the mucosal defense of the stomach or duodenum lead to a mucosal breach. This condition may be acute and transient, like stress ulceration after surgery, or in patient with head trauma or patient on intensive care unit. If the repair system fail to deal with the breakdown of the mucosa, it may become chronic one. البeptic term, يعني term peptic refer to ulcers in the columnar mucosa in the lower part of esophagus. يعني تحدث مو فقط بالستومك ولا بالديودينم، تحدث أيضا lower part of esophagus, small bowel, duodenum, stomach, and in the mucous sac. يعني هاي السايت اللي ممكن يهدف بها البيبتيك ألسريشن. General classification عندنا مع البيبتيك ألسر نقدر نقسمها into gastric ulcer generally, peptic ulceration and atypical ulceration اللي تحدث بأذر sites ممكن. الجاستريك ulceration الميل to female ratio هو 3:1. البيك age of incidence usually in older age group اللي هم above 50 years. عادة هاي تكون associated with H. pylori يعني تقريبا 45% of cases associated with the H. pylori infection, and also associated with a high alcohol intake, smoking, non-steroidal anti-inflammatory use, or and the ulcer associated with the normal or low acid secretion. عادة gastric ulcer could with the normal or low acid secretion. In case of duodenal ulcer أو احنا نسميها مرات type 2 gastric ulceration, يعني duodenal and type 2 gastric ulceration, male to female 5:1 male to female, with the peak age of incidence in the young age group between 25 to 30 years of age. This is associated with H. pylori in about 85% of cases and with a high acid secretion. اللي تختلف قلنا عن الجاستريك ألسر اللي يكون الأسيد secretion بها normal or low, and the associated with smoking and non-steroidal anti-inflammatory drugs. الاتيبيكال ulceration اللي تحدث لنا باتيبيكال site like الميكلز، or تكون مرات extensive ulceration in cases of Zollinger-Ellison syndrome. High classification or types of gastric ulcer اللي يسموها Dietary Johnson classification اللي type 1 in the antrum and near lesser curvature higher in 55 in the antrum and near lesser curvature of the stomach, and type 2 combined gastric and duodenal ulcer with the high acid level. Type 3 the pre-pyloric high acid, pre-pyloric 1 higher pre-pyloric, and type 4 ulcer in the proximal stomach and cardia with the normal acid secretion high type 4. على العموم this is a gastroscopy of the stomach showing here multiple gastric ulcerations higher the stomach, and this is pre-pyloric ulcer, big one, and also we could see residual bleeding يعني يبدو هاي الألسر كان بها bleeding and now it stopped. This is gastroscopy showing a big duodenal ulcer. What are the signs and symptoms of peptic ulceration? The clinical feature of the peptic ulcer could be nausea and epigastric pain. طبعا اكو في بعض الأحيان تكون asymptomatic, presented just by a complication. Just by a complication. يعني قد يكون patient presented by hematemesis or melena or presented by perforation. The other symptoms here, nausea and epigastric pain. The duodenal ulcer characterized by hunger pains. يعني البيشنت يشكو من ألم الجوع. So the patient try to consume food to relieve pain. Usually دول البيشنت يكون normal weight or overweight because of this habit to relieve pain by food, and the pain often cyclical and occur in early hours of the morning. The gastric ulceration characterized by pain precipitated by food يعني عكس duodenal ulceration, and the patient tried to avoid eating, and so the patient usually got weight loss and anorexia. Pain is there cyclical. And vomiting occur sometimes due to pain or sometimes late when there is a gastric outlet obstruction. How we diagnose and investigate those patients? The gold standard in diagnosis هو by gastroscopy, gastroduodenoscopy, which is a commonest diagnostic test showing the ulcer, site of ulcer, and also now it is not a diagnostic, it's also diagnostic and therapeutic at the same time. Barium meal may be used if gastroscopy contraindicated, and we have to search for presence of H. pylori. H. pylori could be investigated or could be seen if there is by urease testing to assess the presence of H. pylori, or by doing enteral biopsy from gastroscopy or by CO2 breath test. Sometimes we need fasting serum gastrin level if hypergastrinemia suspected. What are the complications of peptic ulceration in general? These complications, عادة complication مع peptic ulceration تكون serious and need an intensive resuscitation and management. أول واحد هو acute upper GI bleeding. Patient presented by hematemesis and melena or just by melena. The acute upper GI bleeding, either by fresh blood or coffee ground bleeding. Bleeding should be differentiated from other cause of upper GI bleeding like esophageal varices or like amalurious tear. In cases of a chronic ulcer, iron deficiency anemia could be presented. The third serious complication was perforation. Perforation either into the general peritoneal cavity, like perforated gastric ulcer or gastric tumor, or due to perforated duodenal ulcer. As we said that the anterior duodenal ulcer tend to perforate into the generalized peritoneal cavity, while the while the posterior one need to tend to bleed. In advanced cases, gastric outlet obstruction due to chronic scarring or at or around the pylorus. How we treat the peptic ulcer? Two main lines of treatment, either a medical treatment or surgical treatment. Medical treatment, the principle of medical treatment. The main principle of treatment are to eradicate this bacteria, this H. pylori bacteria, and to reduce and neutralize the acid secretion. Failure to eradicate the H. pylori by giving anti-acid therapy alone or giving a short course or improper combination of antibiotic, this lead to recurrence of the ulceration. H. pylori eradication, there is usually combination of antibiotics and by PPI. This regime given for about 2 weeks, 2 antibiotics. المينستي هو كان الاموكسيدين يعني كان الاموكسيدين والمترونيدازول or tinidazole with PPI قد يكون لانزوبرازول او قد يكون المبرازول. There are طبعا many forms in the pharmacy and brands. This should be given for about 10 to 14 days, and the cure rate of eradication about 90% of cases. طبعا بالإضافة إلى we have to advise the patient to stop taking non-steroidal anti-inflammatory drugs like aspirin, brufen, or any type, and also to prevent the patient from taking smoking or alcoholism. Surgical treatment. Rarely required with a very highly effective acid reducing drugs and eradication therapy. يعني في الوقت الحالي العمليات احنا نسويها بكميات كلش قليلة فقط، تقريبا محصورة الآن على الكومبليكيشن اللي مثل ما قلنا هي bleeding, perforation or scarring or complication يعني transformation into malignancy especially يعني خاصة أو فقط بالgastric ulcer. What are the indications? Indication, presence of complications in the emergency situations. What are the complications of peptic ulceration? Peptic ulcer at any site may undergo the following complications. أول شيء perforation, either into the peritoneal cavity, the free peritoneal cavity, or into the adjacent structures. For example, the pancreas, liver, or colon. Or stenosis sometimes, or as we mentioned that the gastrointestinal hemorrhage, or due to chronicity lead to formation of fibrous tissue and malignant changes in case of gastric ulceration. This slide showing this is a perforated duodenal ulcer. That perforation here, the stomach, that's the duodenum during laparotomy, and we have to diagnose the condition. طبعا لازم احنا نشخصها قبل العملية أكيد. The gold standard احنا عندنا to diagnose the perforated duodenal ulcer هو chest X-ray erect position showing the gas under the diaphragm. هنا عندنا الغاز احنا طبعا نركز الليفت سايد مرات هو obscured by the gas bubble أو يعني gas bubble of the stomach, and احنا نشوف هنا أكثر يكون أكثر وضوحا on the right side. This is the diagnostic of perforated viscous, يعني قد يكون duodenum أو قد يكون any other viscous. This is the perforated gastric ulcer أو قد يكون perforated gastric cancer. The perforation of peptic ulcer is relatively common and important emergency situation. In an emergency situation, the incidence of perforation fell nowadays because of use of PPI and use of eradication therapy. Perforation occur particularly in the young adults. عادة دول البيشنت احنا من يجون للإمرجنسي ديبارتمنت we have to take a good history. ممكن نحصل على history of non-steroidal anti-inflammatory drugs. The clinical feature previous history of peptic ulceration is obtained in about half of the cases. Typically the pain is sudden onset and of extreme severity, and the patient could point to the exact time of beginning of the pain. يعني هو المريض ممكن يقول لك مثلا الساعة مثلا 9 مساء بدأ أو 9 ونص أو بالليل، يعني ممكن يحدد لك وقت starting of the pain. Subphrenic irritation may indicate it by referred pain to one or both shoulder, usually the right one. the pain is aggravated by movement and patient lies rigidly stunned. احنا مرات نفرق بين الألم مالت البريتونيتس, the pain of a peritonitis, and the renal colic. I asked the student how to differentiate between the two. Usually the patient with renal colic try to move around and try to rolling, not in contrary to the patient with peritonitis, that he or she try to still and to avoid any movement. Sometimes this perforation accompanied by hematemesis or marina. On examination, the patient in severe pain. شوف المريض مثلا toxic in pain and sweaty with rapid shallow respiration in the early stages. There may be no clinical evidence of true shock. The pulse is steady and the blood pressure normal. The temperature is either normal or little depressed. On examination, the abdomen is rigid. يعني أول ما تخلي إيدك على الأبدومن you feel rigid abdomen and silent. Although in some instances occasional bowel sound may be heard. Liver dullness is diminished. يعني من يسوي percussion راح تحس بأنه الدلنس مالت الليفر because of the gas escape into the peritoneal cavity. When you do a perectal examination, may reveal a pelvic tenderness in the delayed cases. After 12 or more hours of starting of this perforation, generalized peritonitis occur with paralytic ileus. The abdomen will be distended with effortless vomiting occurs and patient extremely toxic and oligemic shock. What are the investigation as we mentioned here? The chest X-ray showing free gas under the diaphragm in over 50 to 70% of cases. Computerized or computed tomography is more sensitive in detection of a free intraperitoneal gas and could exclude a common differential diagnosis like pancreatitis in doubtful cases. Differential diagnosis. We have four conditions with which perforated ulcer is most commonly confused are: أولاً perforated appendicitis. احنا مرات نفتح على perforated appendix يعني نتوقع هي appendicitis, نكتشف أكو fluid which is bile stain, so we sure that this not coming from the appendix, extend our incision or doing other incision to find presence of perforated duodenal ulcer. Acute cholecystitis, acute pancreatitis. يعني acute pancreatitis, you have to put acute pancreatitis in any differential diagnosis of acute abdomen. Myocardial infarction, you have to put cardiac origin in any differential diagnosis of acute abdominal pain, especially in the epigastric region. In diabetic patient لازم انت تسوي ECG in any case اللي هم above, خاصة اللي هم عندهم history or family history or history of ischemic heart disease. Treatment. In any emergency situation, المانجمنت طبعا هو يشمل diagnosis and treatment. لازم يكون عندنا أول شيء resuscitation by بنخلي المريض أول ما يجي نخليه لازم cannula, nasogastric tube suction to empty the stomach and diminish further leak. This is considered an essential pre-anesthetic measure, and giving the patient fluid, antibiotics, and when we sure of the diagnosis, opiate analgesia given to the patient. Most surgeons prefer an immediate operation to repair the perforation. This type of surgery خاصة بالإمرجنسي احنا we try to do a minimum. This perforation here يعني مرات يكون perforation عندنا wide hole, we cannot suture it immediately, نخلي omentum and we suture the omentum over the perforation. This is called an omental patch or Graham patch. راح يصير عندنا هنا adhesion between the omentum at the site of perforation, and this will enhance the closure of the perforation. Definitive ulcer treatment at the time of emergency rarely required. حقيقة يعني احنا قبل كان يعني يعني قبل ما يعني effective treatment or eradication قسم كانوا يسوون يعني dichotomy يسوي لك definitive surgery for ulcer disease. Now it is rarely indicated or not required. The prognosis of the condition. The mortality for perforated peptic ulcer lies between 5 to 10% of cases. Most complications occur in the elderly اللي هم above 70 years of age, أو هم اللي عندهم underlying diseases, or the patient who presented late for surgery. Otherwise, the prognosis is very good. Pyloric stenosis, other complication اللي هو يصير عندنا هو pyloric stenosis. طبعا pyloric stenosis is an inaccurate term when applied to duodenal ulceration. يعني هو التعبير مال pyloric stenosis إذا استخدمته بالduodenal ulceration ما راح يكون عندنا هنا مضبوط. ليش؟ لأنه الobstruction occur in the first part of the duodenum rather than in the pylorus. The pathology of pyloric obstruction, at first, fibrotic scarring is compensated by the dilation and hypertrophy of the stomach muscle. Eventually, failure of compensation occurs much like the failure of hypertrophied ventricle of the heart with valvular stenosis. يعني راح يصير عندنا failure of compensation. During that, the patient presented by vomiting. الvomiting طبعا هو هنا يكون عندنا خاص الvomiting معناته يعني يكون copious amount. The patient say that the vomiting of previous 1 or 2 days meal يكون smelly, feculent, and because of that repeated vomiting daily or after 2 to 3 days, the patient يكون dehydrated with electrolyte disturbances. The patient is now on examination. The patient appeared dehydrated, underweight, wasted, and progressive dilatation and hypertrophy of stomach can be seen, and the presence of succussion splash elicited by shaking the patient abdomen several hours after a meal. يعني انت مثلا السكشن سبلاش راح يكون عندنا false positive اذا سويته after مثلا الميل رأسا او after the patient drinking water. فأنت تعوف المريض 5 hours 4 to 5 hours after meal, and if the succussion splash is positive, we have to consider pyloric obstruction. Finally, the grossly dilated hypertrophied stomach filled by food and fluid can actually be palpated. When we insert nasogastric tube, sometimes we aspirate a foul smell fluid up to several liters. What are the investigations? The gastroscopy following decompression of the stomach. يعني انت ما تقدر تسوي gastroscopy، يعني ما راح تقدر تشوف اكيد لانه الستومك تكون مليانه by fluid food of previous days, so you have to evacuate the stomach by decompression by nasogastric tube with gastric lavage. The gastroscope will identify the cause in the most cases, either in the stomach or the duodenum. CT scan will provide further anatomical information about the diagnosis and its etiology. Arterial blood gas electrolyte estimation may show hypochloremic alkalosis with hypokalemia and uremia. What are the metabolic effects or biochemical changes or disturbances occur in the pyloric obstruction? Because of repeated vomiting, dehydration, electrolyte abnormality will increase in the blood urea nitrogen and creatinine, which is considered as a late feature of dehydration. Prolonged vomiting causes loss of hydrochloric acid, produce an increase of bicarbonate in the plasma to compensate for the lost chloride. يصير عندنا هنا hypokalemic, hypochloremic, metabolic alkalosis. As a result of alkalosis, shifting of intracellular potassium, mainly intracellular, to the extracellular compartment. سيرم بوتاسيوم راح يظهر لنا بالتحليل بأنه عالي، بس هو هذا false. With continued vomiting, the renal excretion of potassium increase in order to preserve sodium. In case of long-standing pyloric obstruction يصير عندنا paradoxically acid urine. هو المفروض يكون عندنا اليورين هو الكلام، بس يصير عندنا paradoxically acidic urine. ليش؟ Initially the urine has a low chloride, high bicarbonate. في البداية يكون عندنا اليورين chloride قليل, high bicarbonate, which reflect the primary metabolic abnormality. هذا البicarbonate excreted along with the sodium. By time, the patient becomes progressively hyponatremic and more profound dehydrated. Because of the dehydration, a case of sodium retention will fellows and potassium hydrogen are excreted in preference. يعني الجسم يفضل ياخذ الصوديوم يطرح لنا البوتاسيوم والهيدروجين ايون. This results in a urine becoming paradoxically acidic. Alkalosis lead to lowering of circulating ionized calcium and tetany. يعني تفحص الميز تشوف عندك Schwarzschild sign positive for the presence of tetany. What are the differential diagnoses? Carcinoma, you have to put carcinoma in your mind. احنا مرات هاي نسميها pre-pyloric tumors. اللي تشمل carcinoma of the head of pancreas, carcinoma of the pylorus, stomach, and نضيف لها أيضا مرات carcinoma of the ampulla or so هاي كلها تعتبر يعني pre-pyloric tumors. Other causes of pyloric obstruction are unusual in the adult: scarring associated with benign gastric ulcer near the pylorus, carcinoma of the head of the pancreas infiltrating the duodenum and pylorus, chronic pancreatitis. طبعا هنا عندنا carcinoma of the pancreas chronic pancreatitis يعني قد تعطينا أيضا gastric outlet obstruction. Invasion of the pylorus by malignant nodes. The differential diagnosis from the differential diagnosis from a pyloric carcinoma cannot always be established until endoscopy. يعني احنا مرات ما نقدر نوصل للديagnosis إذا بنسوي له patient endoscopy and biopsy, or even sometimes laparoscopy. But a reasonable attempt should be made to reach the diagnosis. شنو هاي الاتمpt اللي by history؟ نتبع following point. أول شيء the length of history. length of history يعني مدة الحالة. يعني إذا كان الهيستوري of for several years، يعني إذا كان المريض يشكو من أعراض قرحة لسنوات طويلة وصار عنده هذا الأوبستراكشن، هذا in favor of benign condition, in favor of peptic ulceration. إذا كان الستومك المعدة dilated, usually dilated، هاي أيضا in favor of benign condition. زين. On examination إذا حسيت mass this indicate a malignant disease. usually طبعا هو malignant disease history مالته for few months and presence of a mass. طبعا الماس قد تكون أيضا related to the inflammatory mass، يعني هي مو شرط تكون يعني هي malignant mass، بس rarely could be a palpable inflammatory mass associated with a large duodenal ulcer could be detected. Treatment. As we mentioned, for the bleeding peptic ulcer, we have to resuscitate the patient. Patient here presented with dehydration, electrolyte disturbances. This should be corrected by intravenous replacement by saline together with potassium. Daily gastric lavage is performed to remove the debris from the stomach. يعني نحضر المريض قبل العملية، نصلح الإلكترولايت، نصلح الديهايدريشن، نعطيه antibiotics أيضا. قد يحتاج إلى كالسيوم، فيتامين سي and antibiotics before surgery. The surgery done by doing the Roux-en-Y gastroenterostomy. Roux-en-Y gastroenterostomy. قسم طبعا احنا نسوي مرات فيجوتومي، انتروكتومي with Roux-en-Y gastroenterostomy. يعني هنا فيجوتومي، انتروكتومي نقص الانترم، and Roux-en-Y gastroenterostomy. Roux-en-Y هذا نقلل البايل reflex to the stomach. In summary, the gastric outlet obstruction is most common associated with the long-standing peptic ulcer disease, or could be related to the gastric cancer or other type of cancer اللي هي مثل ما قلنا pre-pyloric cancer تشمل البنكرياتيك cancers. The metabolic abnormality عادة احنا نشوفها بالhypochloremic alkalosis usually seen in the peptic ulceration due to peptic ulcer. Endoscopic biopsy is essential to determine whether the cause of problem is malignancy or not. Aggressive medical therapy for peptic ulcer disease often lead to resolution of this condition يعني before the scarring. Endoscopic dilatation of gastric outlet may be effective. يعني مرات احنا مو شرط نسوي عملية، مرات بالاندوسكوبي we try to dilate the obstruction and stenosis. Operation is frequently required with drainage procedure being performed for benign disease with appropriate resection in case of malignancy.